So obviously amyloid's a multi-system disorder, so it's good to have someone that isn't a hematologist here. Manisty. Charlotte's head of clinical cardiovascular research at UCL and also currently clinical director of cardio-oncology at the Children's Health Centre. She's going to give us an update on the cardiac side of amyloid.
Sorry, I'm just connecting out my computer. So my major disclosure is that I'm not a hematologist. So apologies if I say anything that's completely incorrect. Sorry, it's not coming up. Let's try that. Good, perfect, excellent, great. Well, thank you very much for the invitation. So why are we interested in cardiac amyloidosis? I'm going to take us back down to earth a little bit and talk much more on the clinical side than we've been hearing just now. Essentially, we're interested because the majority of your patients with amyloidosis anywhere will have cardiac involvement, about 3 out of 4 of them. And also we know that about 15% of patients with myeloma will also have evidence of amyloid at diagnosis. So this is important to understand and to diagnose. We also know that a lot of these patients will come to us through cardiology, and that we're seeing more of these patients, partly because of the increased detection and knowledge about ATTR amyloidosis. So because of the new therapies that are coming through for ATTR, the drug companies are pushing detection a lot, which means that we're picking up amyloid, and alongside picking up the ATTR, we're also going to be picking up more AL. So in terms of diagnosis, we need to be aware of the understanding that patients may present with chest pain, shortness of breath, fatigue, etc. But a large proportion of patients will have a significant delay to diagnosis. More than a third will wait for more than a year. And we also know that patients will see a great number of physicians before they actually end up getting a final diagnosis. We also know that the advances in cardiac imaging mean that patients are being picked up more at an earlier stage with amyloid, perhaps before they develop the florid cardiac phenotype. And also typing is getting to be improved with other techniques. But tissue diagnosis is normally needed, as you'll know. In terms of prognosis, it's obviously the cardiovascular outcomes that determine prognosis, with more than 60% of patients dying eventually from a cardiovascular death, be it arrhythmic death or heart failure. And more than 20% of patients will die within 6 months. But it's also important to think about the impact that heart failure has on hospitalizations. These patients have prolonged hospitalizations. And also the underlying cardiac involvement will determine what treatments your patients are eligible for from a hematological perspective as well. So we really need to understand the cardiac phenotype and the presentation, as well as the underlying hematology side of things. So from our perspective on the cardiovascular side, when we're interested in diagnosis, we want to not only confirm that there's amyloid present and that the heart is involved, also determine the amyloid type, and then the stage and the extent of the amyloid involvement. And so I'm going to take you through a contemporary case, one of our patients at Barts. So this was a young patient, 41 at presentation. She was actually an ICU nurse in one of our local district general hospitals. She presented with symptoms of shortness of breath and fatigue, and perhaps unsurprisingly, it took a while for her GP to cotton on that something might be wrong, and she ended up, as many of these patients do, bouncing into hospital with heart failure. Her ECG and echocardiogram were characteristic, with small ECG complexes, first-degree heart block, and then this characteristic left ventricular hypertrophy, restrictive filling pattern, and then this bullseye pattern on the global longitudinal strain with apical sparing. She had raised cardiac biomarkers and was discharged with diuretics and outpatient routine cardiovascular MR. So there's a series of red flags that help cardiologists in particular understand whether a patient's got amyloidosis, and she ticked for many of them, apart from other systemic symptoms. She then had quite quickly outpatient cardiovascular MR scan within 4 weeks, and this was completely barn door characteristic of amyloid. And so she was known at that point to have a diagnosis of amyloid and was referred to our cardio-oncology unit. Just very quickly talking you through a few of the details around cardiovascular MR. There are many different conditions that can cause left ventricular hypertrophy in cardiology, and you can't really tell them just by looking at the heart itself. But actually, when you give contrast, in this case gadolinium, you can see that there are very distinct patterns, and so you can clearly distinguish between phenocopies. And we also have parametric mapping techniques that are able to quantify the infiltration and sorry, I've obviously got a loose connection here, and then will allow you to have a parameter that you can track over time in a quantitative way. And also, looking at different patterns of parametric mapping, you can see that amyloid is very different to some of the other phenocopies. So this is very helpful for us in clinical practice. So cardiovascular MRI now has a class 1 indication for use in patients with suspected amyloidosis. And we also know that this is going to be of value for, I'm really sorry about this, for prognosis as well, where both T1 and ECV are prognostic in patients with amyloidosis. I'll move on. Sorry. This was working well earlier. Apologies. I'll try and flick through quickly to get to the end and not waste time. There we go, perfect. The other thing that's important to say is cardiac biomarkers, NT-proBNP and troponin, are useful not only for diagnosis, but also for ruling out amyloid. And so if your patient with myeloma has got some symptoms that you're suspicious of, it's worth doing screening with NT-proBNP and troponin, and there are clear cut-offs. And this is data from National Amyloidosis Centre in almost 1,000 patients with a derivation and validation cohort. And you can see that the ruling out sensitivity and specificity according to these cut-offs, NT-proBNP of greater than 180, a troponin of greater than 14, or a high sensitivity troponin T of greater than 96 for a diagnosis of amyloid is extremely useful. And so for screening in your myeloma population, this will be helpful. DPD scanning, this is particularly useful to us as cardiologists to help determine whether someone has got ATTR or AL. We know that if you've got a positive DPD scan, it's likely that you've got amyloid, but it's more commonly a grade 3, 2 or 3 output in patients who've got ATTR amyloidosis. So most patients with ATTR will have a positive DPD scan. But if you have a positive DPD with grade 1, it may be that you have AL. So 40% of AL patients will have a grade 1 or greater DPD. But this is helpful to us as cardiologists for our typing. Obviously, for tissue diagnosis, we could go straight into doing endomyocardial biopsy, but it's invasive, it's not available in many places. So we do rely a lot on other tissue, both bone marrow and fat pad biopsy, which we do locally at Barts, where we know that there's a quite high sensitivity with AL amyloidosis. And we often end up sending our histology to the NAC for second review if needed. So going back to our case, she was then seen in our hospital. She had all the usual things done. She was DPD grade 0. She had a kappa myeloma with serum-free light chains of 180 kappa. She had 16% plasma cells in her bone marrow. Her fat pad biopsy confirmed AL amyloidosis. And so because she was Mayo Stage 3A, she was started on VCD. Daratumumab was not available at the time, and supportive cardiac therapies. Just to remind you of the staging system, we've just heard about the new staging system, also including global longitudinal strain. But certainly back then, this was the staging system we were working on, with her biomarkers both for NT-proBNP and troponin being significantly elevated. And we've seen this curve already showing a significantly poor prognosis in patients with stage 3A. So 20% of patients have stage 3A at diagnosis with a median survival of about 14 months, which obviously for a 41-year-old is quite devastating. So moving on to treatment, obviously this audience knows well that the aim of current treatments is to reduce the clonal precursor proteins using chemotherapy. And ideally, what we're trying to do is to basically increase clearance and reduce deposition. We don't have a method at the moment to reduce clearance, so increase clearance, but for deposition, obviously we have the chemotherapy to switch off light chains. Organ response and regression is quite slow in the heart, within taking a median of 6 months before patients who have any organ response, and about 2 years before they get their best response. So in terms of treatment algorithm, you'll know that nowadays we use Dara-VCD for the majority of patients who are transplant ineligible, and that for us is the majority of patients, to be honest, particularly because a large proportion of that is governed by cardiac factors. Before starting treatment, we recommend that all patients have a Holter monitor to look for any arrhythmias or conduction abnormalities that mean that we should be monitoring them more closely or putting a pacemaker in before starting treatment. Consider admission for inpatient monitoring for treatment initiation in high-risk patients, and we do that in quite a lot of patients at Barts who present with late-stage disease. In terms of heart failure management, as we've heard, MRAs and diuretics are the predominant therapies that are used, but the diuresis can be really challenging. A lot of these patients have got autonomic dysfunction and may have very low blood pressures, and so it can be very difficult balancing both their renal impairment, their blood pressure, and their heart failure. As we've heard, ideally avoid beta blockers, vasodilators. We often give midodrine for postural hypotension in patients who have got intractable hypotension. Anticoagulation have a low threshold if your patients have got atrial fibrillation. And we do consider giving antiarrhythmics in patients who are getting a lot of ectopy, for example, on their Holter monitoring before starting treatment. In terms of pacemaker implantation, we do see a significant proportion of patients who've got fairly high-grade conduction abnormalities before starting treatment. And in those patients, we often would implant a pacemaker before starting them on treatment. But the use of ICDs, as we've heard, is relatively controversial, mainly because these patients end up with PEA arrests that don't respond to the ICDs, although we have implanted them in some patients who are having pacemakers otherwise, or for secondary prevention in patients who've had arrests. So moving back to this patient, she had 8 cycles of ECD and had a good response, very good partial response. She also had a good organ response, and so she was doing well. So she's continued then on DARA, on DVD, and has done well since then. When we're looking at organ response, we're obviously monitoring biomarkers, but the other thing that we can do is use cardiovascular MRI. These quantitative mapping techniques, such as T1 and ECV mapping, allow us to actually give a surrogate measurement of what's going on within the myocardium in terms of amyloid burden. So we can see that there were reductions in time, both with LVH, T1 and ECV in patients who respond well. And we also know that organ response will determine prognosis as well. So if we look at this cohort of patients from the National Amyloidosis Centre who are treated with AAL, and look at 6 months and see at those patients who have had regression in their amyloid, you can see it's those patients who have the best prognosis. And by 2 years, you can see that people continue to get regression over the 2-year period. So even though patients may not have a very rapid response, they may continue to have a response further down the line. So going back to our patient, where is she now? She's doing extremely well. She's actually back working as an ICU nurse. She's on continued maintenance daratumumab. She's now had 50 cycles. Sorry, it says 10 there, so she should have 50 cycles now. And she's doing extremely well. But obviously, when we're thinking about these patients, mortality early on remains high, and options for advanced disease are relatively limited. We know that Andromeda excluded patients who are Mayo Stage 3B, but yet we know that the relative benefits of daratumumab in the 3A patients was as good, at least, as the patients with earlier stage disease. So we definitely need more therapies for these patients with advanced disease. When we look at treatments that are currently available, they focus on eliminating the plasma cell clone, as you know, but future treatments may help to eliminate amyloid, prevent it being deposited, or remove it from the system altogether. Hopefully that will allow us to have a quicker response with these therapies. And as we've heard, there are various investigational treatments which are monoclonal antibodies that were currently under development. But unfortunately, we've heard in the last 6 months or so that both bertimumab and KL did not meet their primary endpoints of their studies, which was disappointing, obviously. But we've heard that BCMAs are a future potentially for these patients. And this paper, which we saw presented earlier, you can see that there's a significant proportion of these patients that actually ended up having a cardiac response as well. So that's promising. And of course, we've got ADCs and CAR-T as well. We've got future diagnostic options. There are novel PET tracers that allow us to look for other organ involvement, including the liver in the case of this one. And there are also new AI tools that allow us to be able to track disease and see whether our patients are responding on echocardiography rather than having to rely on MRI. So in summary, cardiac involvement is obviously extremely important and common in the amyloid population, and we're getting more attention from the cardiology community, and that's partly because of the story with ATTR, where there are new therapies coming out that are working well. These patients often present via cardiology pathways, and cardiac involvement really does impact not just prognosis, but also treatment selection, so it's important. We've got improvements in the diagnostic pathway, but we also need to concentrate on trying to support them from a cardiac management point of view, and we don't have many cardiac-specific drugs that are actually helpful in these patients. But the key is that we need a multidisciplinary approach, and many of my colleagues are here today, but the team that we work with at Barts is really fantastic. We do a joint clinic where we actually see new patients together at the same time and cover both the haematology and the cardiology points of view, but also with our specialist nurses in attendance as well. So the future's bright, but I think there is still some caution in these patients who present with late-stage disease, which is a lot of the population that we have, unfortunately. So thank you.
Thank you, Charlotte. We'll take questions at the end.